So we are looking at chapters 3 and 4 today, which is going to be our sports performance testing chapter as well as our flexibility chapter. So we'll talk a little bit about like all the normal fitness assessment stuff, but our tone's gonna be a little bit different today because obviously this is not necessarily just about someone who has like maybe aches and pains and how to like adjust those through their posture. This is really much more about like an athlete who's trying to perform at their highest. Now that being said, obviously, like if you have an athlete with altered posture, and you're able to like fix that posture, they're going to have greater performance. So it definitely still applies. But you're going to see subjective and objective information. Again, we're going to kind of break that down, and we're going to kind of move through that pretty quickly because I think we've spent plenty of time on that in this module. But our objectives of sports performance testing a little bit different than our objectives for your standard fitness assessment situation. Obviously, when you're bringing someone in, you want to explain to them like exactly what it is you're trying to achieve. Like I was watching a fun video recently, actually. It was like training for the NFL Combine, and I always love the NFL Combine because it's like any sports performance like thing is going to be good, but like it's always kind of fun to watch like the NFL Combine in particular because it's such a big event and it's really been boiled down almost better than it's almost been boiled down almost better than any other pro sports testing protocol. I mean, obviously there's like there's spring training for the MLB and there's all kinds of really fun stuff out there, but like I just really love like watching the NFL Combine. But if you look at like this fun video, there's a really good breakdown by the trainers in the beginning because they're like, look, we're not talking about playing football here. We are talking about how to perform well in these assessments. So I'm not gonna watch this whole video here. Is this the one I want? Which one is it? I think actually maybe the second one. I think it's this one here, but here's a fun intro that really summarizes quite well what we're looking for in sports performance testing. Let's see if I'm right here.
Have 2 runs for the rest of your career to make sure that you only have 2 runs for the rest of your career to make sure that you execute and put this on your resume as your best 40 you've ever run your entire life. I talked to them about taking the brakes off the beginning. And so to start, there are no brakes. There are no stops. It's all go. In the middle of the 40, I tell them to melt the middle down. So we're coming in hot like butter. On the back end, we want to blaze the back end, just fire on the back end. So I think that sort of resonates with the guys as they're running through to understand that we're going to have to be fast from the very beginning of the 40. Oh, come on. Let's get it, arms. Yeah.
I'm not no average speed receiver as a 4.5, 4.4. Some people got me running a 4.5 and I just want to show people that I'm way faster than 4.5.
That's better. See you later. That's better. If I'm in my start position and I'm down here, right? Once I take off, where my hips gonna go? They're gonna come up.
Michael Johnson.
So let's start with the hips in the position where you run.
The first Usain Bolt, man.
I started to understand that there's a real technique to sprinting in the 40-yard dash.
Well, we're talking about 4.3, 4.2 speed. Inches matter. I'm looking around.
See how much emphasis they're putting on like, I mean, they're like this guy's watching a video of his form, like breaking down exactly what the perfect angle is. I mean, they're assessing everything just to, squeeze out 0.1 more seconds on like a 40-yard dash, like that's crazy. They're putting all this effort in because, in order to get into this like field, in order to be a pro NFL player, you gotta leave it on the field one time, and it is like you said, you're gonna put it on your resume almost, So I just really love like the perspective of this class, and if you guys want to look those videos up, they're really fun. Just look up like training for the NFL Combine. There's some really great stuff on there. So anyway, our objectives today, we want to explain the components of sports performance testing. That's going to be your 2 major components, subjective and objective, as well as all the subcomponents like PARQ, general med, physiologic, cardio, strength, whatever. Understand the difference between our and understand, clearly our 2 types of different, types of different information. When it comes to sports performance testing and any fitness assessment, we've talked about this plenty of time. Our goal is to figure out like what our client wants to work on, what their needs are, and then like what they're sort of like what they're coming in onto the field with, what their already sort of naturally gifted abilities are, right? So like goal wise, do they want to improve their lean body mass? Do they want to improve their speed, their agility? Do they want to improve their strength? Like, what is the overall goal? That's something that can be obtained pretty easily in the beginning with like an interview during your general medical and history questionnaire. You're going to talk about like those, get those questions out. But then also we need to figure out like what their needs are, and a lot of that is going to come through like performance testing, postural assessments. Like if I see someone, who's got like knees caving in, or they feel a pinching in their hip during a barbell squat, or, they have a really hard time keeping their low back flat during like a deadlift or something. We're going to look at like what's causing those postural distortions. What do they need? Like what exercise, what muscles need to be turned on, what muscles need to be turned off in order to get this person like back to a place where, their body can move the way it was designed to. And then we will look at their natural abilities. Like I said, performance assessments are going to be great for that because, if we see that someone is super speedy, we can kind of build on that foundation. Now, obviously, just like any other fitness assessment situation, we do not use this to diagnose any medical conditions or anything like that. If an athlete if we see somebody has like an excessive forward lean, for instance, we know that sometimes that's either associated with like tight hips or it's associated with like a tight ankle complex, right? That's what causes our excessive lean. And then if they tell us like on their injury general medical questionnaire, they're like, oh yeah, I sprained my ankle a couple years back, and it never felt like it healed properly. And it's like, okay, like that's something that like we can address through like postural distortions, but like our job is not to assess and be like, oh yeah, you've got like arthritis in your ankle, there's scar tissue in there, we need to do something about that. That's not really our job, right? Like our job is to look, it's like, okay, you do have altered posture. Let's see if we can do anything to adjust that altered posture. And then at the end of the day, all of this, the main reason we're doing any of this is to get an individualized program for every single one of our athletes. We want to make sure that like we use our fitness assessments to be very specific. I think that like by now, like I said, we had an entire assessments class. You guys have a pretty good understanding of why specific is always going to be better than not specific, right? But we also kind of tied that together. If you remember pivoting into our sales class afterwards, writing specific workouts for someone that are tailored and catered to them rather than just being tailored or catered in general. When we do that, that has a much more positive effect. That's an easier sell for us as well, because like, obviously that's something somebody's going to want to, purchase. They're like, oh, this was made for me. So always like good things to remember. So first part of an assessment is always going to be our subjective information. This is our information that, cannot be measured. This is our, a lot of times this is a very, very important information, but we can't, measure it in the beginning and measure at the end and like look for improvement. That's not really sort of the goal of subjective information, right? For instance, our PAR-Q, our physical activity readiness questionnaire, that's subjective. And that's going to determine their readiness for being able to engage in like a fitness program, right? So we want to be able to use the PAR-Q to determine if our client is ready to engage in physical activity or not. It's most of the questions on the PAR-Q are related to detecting any cardiorespiratory dysfunction. There's one question related to like the skeletal system, but most of it is like, it's like, hey, do you have chest pain? Hey, do you have shortness of breath? Do you ever get dizzy? It's all questions about cardiorespiratory. You always want to start with that just in case like somebody does have any of those problems, do you ever lose consciousness or dizziness, taking any medication for your heart. We just want to ask those questions, get them out of the way. I mean, most of the time if you're training an athlete, most of these are going to be immediate no's. But if you get a yes to any of these questions, it'll say like, if you've answered yes to any of the above questions, consult your physician before engaging in physical activity and tell them which questions you answered yes to, and then after a medical evaluation, we can determine if like exercise is appropriate or not, right? Now, most people will honestly like already have been to their doctor a lot of times. If they say yes, it's interesting. Like most people are gonna, just say no to everything. But when people say yes, generally it's not like they're like, oh yeah, I have been losing my balance and getting dizzy and passing out a lot lately. And it's like, have you talked to your doctor about that? And they're like, no, I never really thought about it until you put it on this piece of paper. No one's going to do that. Like no one is going to be like, yeah, I get chest pain every day. You haven't seen a doctor about that? No, figured I'd come see a trainer. Like that's not the world that we live in or the way people work. So most of the time, like if someone says yes to this, you want to make sure you have, like, I'm not a huge fan of the way they phrase this. You want to make sure they have a doctor's permission before exercise. Doesn't mean that like you have to send them away in that moment. You just have to say, okay, well, like, have you been cleared by your doctor to do this? It's like, did you ask specifically if you could start exercising? Or did your doctor tell you to start exercising? Yeah. So that's our PAR-Q, right? That's that physical activity readiness questionnaire. Now, other part of our subjective information, we have the general and medical history questionnaire, which are general questions about your general and medical history. So they're related to your medical history, your background, hobbies and interests, we're going to ask about like certain injuries, especially in like the athletics world, because like there's no athlete out there who's never gotten hurt before. But it's really helpful for you to gather information about like if they have any nagging injuries or if they've had any surgeries or anything like that. It's also going to tell you about any like comorbidities that they might have. If they say that they have like hypertension or asthma or anything like that, we're going to learn a little bit about that. And then any medications that they're on. And if they are on any medications, we're going to check that list and see what any of the possible effects are. I don't think you necessarily have to have every one of these medications memorized. But if you look at like, if you look at this list and just have a general understanding of like what they're used for, if they're on like a vasodilator, that can have a lot of different effects on their heart rate, but generally it lowers their blood pressure, so if you find that like all of a sudden your client is getting a little bit dizzy because maybe their blood pressure got too low, they might get like lightheaded for a second because blood's not getting up to the brain. And you guys have experienced that if you've ever like jumped up really suddenly and like all of a sudden you get a little like spotty vision. That's because all your blood is trying to be back on the couch. That is my favorite way to phrase it is it's a sudden and very dramatic drop in blood pressure. Doesn't feel good, but like, for the most part, it's relatively okay. But if that's something that happens like really chronically, it's like, maybe your client is experiencing like alterations in their blood pressure. And we want to get all this information out ahead of time. It's probably not going to have a huge effect on your first couple sessions, if I'm being perfectly honest. But knowing their medications, you ask these things up front so that you have them in the back of your head, you're aware of them. And then let's say you're training your client for 6 weeks, right? You've been working with them for a while. Let's say they're a diabetic. Diabetics are a great example of this. And they're on insulin or maybe some other diabetic medication. And they start talking to you, you're in the middle of your session, you're talking, and they start to get like a little like woozy. And it's like, oh, you okay? And they're like, yeah, I just feel really nauseous and woozy. And I just don't feel very good. And it's like, it's been happening a lot lately. And it's like, really? And they're like, yeah, I feel like I've had kind of like low energy lately. And I've just been, kind of sapped and this and that. And it's like, well, we've been working together for 6 weeks. You've dropped, let's say, like 5 or 6 pounds at this point. And like, you've improved your strength. And like, we've been working pretty hard in like this specific training zone, which means that like you've been using a lot of glucose for a fuel source lately. Have you talked to your doctor about like adjusting your insulin medication? And I'm like, no, it hasn't occurred to me. And it's like, maybe make a doctor's appointment. And then if it turns out they need less insulin because through exercise, they've increased their sensitivity to that hormone, that happens a lot. Yeah. And that's why we want to be aware of like what these effects are of this medication. If you have a hypertensive client and all of a sudden they start to, get that spotty vision that I just talked about whenever they move their head too fast. I'm like, yeah, it's been happening a lot lately. And it's like, what's your blood pressure? But it's like, yeah, lately I've been, crushing it. It's been low every day. And it's like, okay, well, if it's been low every day and you're still taking the same amount of medication, like maybe it's time to go talk to your doctor about that. We're not telling them to take less or more of their medication. What we are doing is we're encouraging them to speak to their physician about making an adjustment. If their doctor says, no, you haven't made that many adjustments yet, this is still totally the right amount, great. That's fantastic news, like business as usual. But if their doctor's like, yeah, you know what, you've increased you're clearly a little more sensitive to insulin, your blood pressure is clearly like, managing itself and staying under control much better, like let's lower your medication, that's even better. That's the best news. But we do not do any of that. We do not administer like medical exams. That's not part of our job. Now, from there, we've got our sort of bigger category here, which is all of our objective information, right? This is the information that can be measured. A lot of objective information, we usually use it. It's typically number-based. It's not always number-based, right? Like for instance, like knees caving in is not like a number situation. I mean, obviously it could be, by the way, like if you use like a knees caving protractor, if you use like a protractor and look at like how much someone's knees cave in, and you actually measure like that angle. Yeah, see, I can't even find somebody actually doing it. Here, kinesiology. Obviously these things can, oh yeah, of course it's going to be like, you want to buy one? Anyway, you'll see like, just a picture of what I want to see here. Internet, please, for the love of God. Kinesiology protractor used on a client. Yeah, great. Okay, that's close almost. There we go. So if you measure like, how much someone's angle, there we go. We can see like how much neck flexion they have. If you're measuring those things with an actual protractor, sure, they're number-based now. But generally, like we are, it doesn't really matter how much someone's knees cave in. If it happens, that's dysfunction. That's them moving in a way that they're not supposed to. So 5 degrees and 10 degrees, those are obviously a huge difference. But either way, it means the same thing in terms of what needs to be stretched and what needs to be strengthened. So they're measurable. They're just not number-based. So objective information is very much measurable. We're looking for improvements over time. These are really great type of assessments that we can use to compare your beginning numbers to your ending numbers, and a lot of this objective information, a lot of this objective information is going to be providing you with information about like a lot of different categories. So we're going to go ahead and look at these basic categories. We've got physiologic, postural, and performance. These are sort of our main ones that we're going to be looking at today. Your physiologic assessments, when we say physiologic, what we mean is like it's related to like your heart and like your lungs and stuff. One thing that they're doing here, this is one thing that I hate, by the way. This is, by the way, Charlie and Robert, this is why like we don't strictly teach out of the performance book and why I spend a lot of time talking about always going back to regular NASM. I like the information in this book, but sometimes NASM is a little inconsistent about how they present information because like, they're presenting it from a specific perspective, and things look different when you're talking about different populations. So they are putting circumference measurements and body mass index here under physiologic assessments as a category, and these would be considered body composition assessments in your regular textbook as a category. That's not really important in terms of like how you're going to be tested. Like NASM's not going to be like, what are the 5 things found in the body composition category of fitness assessments? That question, no version of anything like that question exists. But when you're learning this, it's always helpful to compartmentalize information and keep it in the right categories. So I will say, for those of you guys have both been through PFT 101 and you've seen these categories, they're going to look, just a couple assessments are going to be in sort of the wrong categories today. Just be aware of that and accept it and move on. So physiologic assessments, typically this is things like heart rate, blood pressure, measuring someone's target heart rate, for instance, getting those numbers laid out ahead of time. That's all like part of the physiologic stuff. Then circumference measurements, body mass index, body weight, all that stuff is typically body composition assessments. This is where we do like, if we want to figure out like how much body fat percentage someone has, we got a couple different ways we can do that. The most convenient for sure is bioelectric impedance. That's that, one that basically zaps you. You stand on a scale barefoot and, hold the electrodes, or maybe you're just holding on to the handheld one. But it's just sending an electric current through the body, and it's going to tell you like, what your body fat percentage is that way. Another version that's like fairly convenient is the skin fold thickness using the Dernan-Wamersley formula. So we do a foresight method at NASA. We use the biceps, the triceps, the subscapular, which is back here. Why did I touch this? And the iliac crest, which is there on the hip. Those are sort of our foresights that we usually focus on. There's other methods out there, by the way, and I don't think they're bad. I just think that that's sort of the most convenient, and I'm not sure that it gets more accurate, using any of the other versions. So why use them? And then we have underwater weighing, which is the most accurate. That's the best one that you can do, just because we know exactly how much fat weighs in this world when it's underwater. So that's actually a really easy way for us to tell how much body fat someone has. And then this word that I can never say, we also have, and we probably didn't talk about this, but whole body plethysmography. I can never say it. I've heard people say it a million times, and I attack the word too. I attack it too hard in the beginning, and I know it messes me up, but it's the bod pod. It basically looks like that egg from Austin Powers that Dr. Evil gets into. And basically it's just like hydrostatic weighing, except that this version is using like air displacement. And so, you sit in this little chamber here, and it pushes air into and out of the chamber, and it's measuring how much you are displacing that air. If you have a lot of resistance to that air, then the tissue that's being, pushed is pretty solid. That's probably not body fat. But if there's not very much resistance, that means that a higher body fat percentage. So that's the bod pod. It's much easier to say than this nonsense word. So those are our physiologic assessments. Then we've got postural assessments. Postural assessments, these are designed to, we're really looking at like structure and function here. We're trying to figure out like, which muscles are causing this athlete to maybe drive the wrong way through like their stance leg, which is causing, a loss in power, So we're looking at the alignment, function, structural, all the how efficient their body is able to move. And so we get a couple different postural assessments, We've got our static postural assessments, which actually isn't even on this list right now, but like our three major categories. You've got static assessments, transitional assessments, and dynamic assessments. Static assessments are, a static postural assessment. You're literally going to look at someone and determine like what can you see? If you're looking at their overall alignment, you're gonna look from the front, you're gonna look from the side, you're gonna look from the back, and you're looking for, little bits of like alteration, right? I thought this guy had a scoliosis. I thought when I first glanced, I was like, oh, he's tilting. But we're just looking to see like any of that, any of those altered angles, That's interesting. Like, it's almost, yeah, that's actually fine. I was like, this may be an anterior pelvic tilt, like when it was the picture was small. This guy keeps fooling me. But that's actually totally at a normal angle there. It's the shorts that are pulled down. But we see something like this, right? We see like that kyphosis, right? We see that anterior pelvic tilt, creating that excessive low back arch. That's what we're gonna look at in a static postural assessment. Then we've got dynamic postural assessments. Dynamic means movement. So like, putting someone through like a squat range of motion or a pushing assessment or a pulling assessment, all of those are very dynamic, right? Because like they are going through movement. And then we have transitional assessments. Transitional assessments are kind of a new one. When we look at something like the LESS test, the landing error scoring system. So we're actually going to look at someone as they jump, and we're going to look to see like how they're able to handle that jump. And so they basically do perform the depth jump, right? They're going to start on a box. They're going to jump down to a target that is, I think, half their height in distance away from the box. So if they're 6 feet tall, you go 3 feet out. They land and then they jump straight up, and you're looking to see like as they transition through that full range of motion, like what happens. So like see this athlete right here, right? She's gonna jump down, and then see how she's got like a little bit of knee valgus. So we can think of this as like a progression to the overhead squat, right? But we can see like her knees are slightly caving in, a little bit more on this side than this side, right? And then we look to see like, do they have excessive lean in one direction when they land? She's doing actually a pretty good job of like having a pretty decent angle here. So we're gonna look at a couple of those things, and we'll break that down a little bit. But you use like a scoring sheet, right? Basically, you use this little scoring sheet here. And what we're looking for is like, was their stance width normal? Then, and this, by the way, this assessment is kind of like golf. You want as low a score as possible. The more points you get, the worse you performed. So, did they have a normal stance width? Then they get 0. Were they too wide? Were they too narrow? That's worth 1 point. Did they have any rotation of their foot? Like looking at this girl here. Yeah, no, both toes are totally forward. That's pretty good. So I'd say like, that's a pretty normal stance there. Then we look for initial foot contact. This is kind of a fun one. Did they have symmetrical? Were they symmetric or not, right? Did they land with one foot first? Was one leg forward and one back? How did that look? That's the symmetry we're looking for. I'm assuming this person's pretty symmetrical here. That's kind of hard to see in a photo. Did they have any knee valgus, right? Was there a very little bit of knees caving in, which is what I would say here, just ever so slightly? Or do they have like a lot of knee valgus, right? I'm going to show you a video of the Les test in a second with like a teenager doing it, and like his knees are like, did we see any lateral trunk flexion? Like, do they sit into one side when they jump? I sometimes do that. Small to mine, that's worth a point. Did they land toe to heel, which is what we're looking for? Did they land heel to toe or flat foot? So many CrossFitters, this drives me insane, and I swear it's a CrossFit thing. Or you'll see it in like a lot of gyms. You see this kind of stuff.
Let me guess. You're too busy.
Oh, quiet, Alec Baldwin.
Just like you were too busy to invest in Bitcoin.
Get here, Jack Donaghy.
Start off on 12 or 6 or just your hips by
Let's see how he does. This guy's demoing it for teaching purposes.
You're also going to use
Ooh, okay, that's really good actually.
by swinging them back as well.
I think it's good.
Here, explode.
I mean, he's talking over it, so I can't really hear, but that looks pretty smooth on the landings, right? What we see all the time is people like, wham! Let's see here how she does. So that's all flat-footed. I mean, this is a box jump, which is very different than a depth jump. So it's okay to land, a little flat-footed here because there's not as much energy coming down. But what I want to find is like how freaking loud it is. And that's where you see people like landing heel to toe, and you're like, good Lord, like the amount of impact traveling up your entire body. So initial toe, like landing in a depth jump, we want to land toe to heel. Your toes are your shock absorbers. We want that to like hit and then slowly lower you down. Was there a certain amount of knee flexion displacement? Now, talking about like knee flexion displacement, what we mean is like, are the knees traveling super far past the toes, right? So if we look at that, see if I don't even know if I'm going to be able to find a picture of this. It's the same lady. No, I'm really not going to get it, am I? So are they excessively going like with their knees super far past their toes? Look at that. We can see the feet turn out, knees came in. And then also like, are they landing like into a full super deep squat? Remember, that's what knee flexion is, right? So like, are they landing and like, when they hit the ground, are they able to kind of handle that force, or are they like falling down and then all of a sudden their butt hits their heels, If they are, that's like, whew, that's a lot of like, that was very difficult for that person to land. So if they had an average amount, that's okay, and a small amount. And then amount of like trunk flexion displacement. So we're looking for the same thing, like, do they have like, an excessive lean, or like, do they, land efficiently? Then this is kind of an interesting one. This is the one that always kind of freaks people out, and I think this is kind of weird too. Total joint displacement in the sagittal plane, soft, average, or stiff. This is really just you judging how are they landing. Are they landing really soft? Are they landing really hard? You know, like if you're just looking at them, like how much like major impact is happening. If there's a lot of impacting, like, you know, they're like rickety every time they land, you know, that's pretty stiff. We want them to land like nice and soft. And then we do have room here at the end, which is really just an overall impression of like how you feel about this is another one that I think is kind of weird, but like, you know, did they do a good job, or were they average, or did they do poor? Like in stuff that kind of doesn't fit into any of these categories. So I want to find, there's one of it's like I think it's this one. It's like this teenage
I'll
kid.
be evaluating the landing error scoring system, or the LESS assessment. This is a great test for indicating if an athlete has a risk for injury during jumping and landing movements. It's a good test for most sports because most sports include jumping. This will be based on a 13 yes/no questionnaire assessed by a sports performance professional. The lower the score, the less risk of injury. It begins using a 12-inch platform, and there will be a mark out in front of the platform that is half of the height of the athlete. They'll jump off 2 feet, land on 2 feet, jump straight up, and then repeat the process. The evaluation begins with the athlete standing on the platform, jumping off the platform, off of 2 feet, landing in front of the.
Do you guys see how much is going on in his foot and ankle complex? Do you guys notice that? Like, look at his feet when he lands. Also, he shouldn't be. This kid's like bouncing back to get like the reps done really fast. You don't need to do that. But take a look here.
And then repeat the process.
Watch his.
The evaluation begins with the athlete standing on top of the platform, jumping off the platform, off of 2 feet, landing in front of the marked area, on 2 feet, squatting down, jumping straight up, no.
I mean, you can even see like he's got a little bit of knee valgus. His adductors are taking over even before he jumps. Like, watch his knees cave in. You see that? Here, we'll go a little bit in slow motion. Oh, and I'm going to mute that because nobody wants to hear that. So, not bad, knee valgus, right? And then not bad, there, you know, and then knee valgus. A lot of ankle movement as well, right? And then we would also want to obviously see like a lateral view. So we can see some trunk flexion there, right? He's definitely like bending his spine rather than keeping it in like a neutral position. If we look at the angles here, that's a pretty excessive lean while he's doing this. And then as he jumps, right? And he's landing toe to heel, which is great. So, you know, not to say this kid is unathletic. That's definitely not like what we're looking for here. But what this is showing us, right, is that he may be at greater risk when performing jumping activities, right? So if we are his trainer, you know, we are starting him in stabilization first. And when we're doing reactive exercises, which we're going to talk about tomorrow. Yeah. Tomorrow? No, maybe I think we're talking about on Wednesday. Whatever. We're talking about this week. When we talk about reactive exercises, those explosive, you know, jumping exercises, I'd say landing mechanics are going to be a pretty big freaking priority for us until he gets really, really good at it. And then, you know, we can progress it and, you know, we're going to make him an awesome jumper. So I kind of got ahead of myself. I got really into talking about the LESS test, and I was only trying to intro it. But really quickly, going through our posture assessments, we've got the static, right? Static postural assessments are, you know, we're going to look from the side view to look at the overall alignment of the kinetic chain. You know, is the anterior pelvic tilt happening, or is the posterior pelvic tilt happening? You know, do they have that excessive low back arch? Do they have that lumbar kyphosis? Are they rounding their shoulders, right? Ideally, what we should see is like ears in line with shoulder, in line with the middle of the hip, in line with knee, in line with that knob on the outside of your ankle, right? So we're looking for good alignment all the way up. And then this is sitting nice and level. From the back view, same concept. We want everything to be nice and level. We're looking for any asymmetric shifts that might be happening. You know, if they're tilting this way, for instance, we know that maybe that QL, which is attaching that bottom rib to the pelvis there, maybe that's pulling them to the side a little bit, and then it's loose on this side. So that involves like they need that little bit of like lateral movement. Maybe they have like one foot that's turned out way more than the other one, maybe like a professional driver or something, you know? And what that's causing is like tightness here, which is causing rotation, which is causing, you know, alterations in the pelvis, and then it'll jump to the other side there. So we're gonna look at those, and we would do a frontal view as well to look for knee valgus. I don't know why that's not in the PowerPoint. But we'd look to see, you know, from the frontal view, are their knees caving in, you know? Are their feet turning out? So those are our static postural assessments. Then we have like our overhead, right? These are our dynamic assessments. The overhead squat is, you know, a postural assessment designed to give us insight into overactive, underactive muscles during a squat, right? I guess these are under the transitional category. I swear that's back. I might be off on this. This is why these categories, like, they don't really lay this information out again, but I guess this is the transitional assessment. I apologize, but overhead single leg push and pull are transitional, and then the less test is dynamic. I swear that's wrong, but I guess I must be wrong because it's written down here. But your transitional assessments, right? The overhead squat, we're looking to see, you know, those overactive, underactive muscles. Like, how do they move during that? Because like this is exactly the same as the static assessment. It just puts more stress on certain muscles, and do those muscles give in to that stress? You know, same thing with a single leg. If somebody has like a perfect overhead squat, give them the single leg squat. And then if their knees cave in, now we're starting to find it, you know? I'm not saying we're trying to like, you know, we're not trying to just add more and more variables until we finally find something wrong. Our goal is not to like dig for something wrong. We are just trying to put enough stress to figure out, to determine like what exercises we need to give our client. And let's just say, for the sake of argument, you get the perfect client. They have no overactive, they have no underactive muscles. Great. You're going to stretch, you know, you're going to do dynamic stretches before every workout, and you're going to static stretch whatever they worked out that day to make sure they don't develop any overactive, underactive muscles, and your job gets to be easy, you know? But single leg squat assessment, this is going to give us a little bit about ankle proprioception and core strength as well. A little bit more so than the overhead squat, just because like obviously they're balancing on one leg. The pushing and pulling assessment, this is going to give us insight into the upper body. The overhead squat's great. It just doesn't do quite enough for like the scapular movements. You know, obviously there's some shoulder joint action that's happening, which we're looking for that arms fall forward. But in terms of like shoulder protraction, retraction, elevation, depression, stuff like that, that's where we really want to dive into like the pushing and pulling assessments. And then, like I said, we do have the LESS test, right? That landing error scoring system. Looking to see, you know, is your client capable of landing in a way that is not going to be detrimental to their body? Are they landing the way they really should, you know? Those are our sort of assessments to determine like what exercises to give our client. And by the way, the LESS test, it's not necessarily a postural assessment, but if your client experiences knee valgus, like let's say they did the overhead squat perfectly, they did the single leg squat perfectly, and during the LESS test, their knees cave in. The LESS test is not necessarily a postural assessment used for overactive, underactive muscles, but like, are you going to use that insight to be like, hey, we should stretch your adductors? Probably. Hey, we should strengthen your medial glute. Yeah, of course, that's a great choice, you know? The LESS test is not officially a posture assessment, but remember, like there's a great quote that we watched in one of our videos, in one of our classes, right? Where we were talking about like every movement is an assessment, and every assessment is movement, you know? So if you see, or every exercise is an assessment. So if you see something during the LESS test, great, stretch out those muscles, you know? Any questions on that before we wrap this up on performance assessments? Charlie, Robert, you guys feeling good? Cool. All right. So let's look at let's look at the performance assessments here, right? So your performance assessments are typically related to, whatever athletic event you're going to be performing. But there's a couple general ones, like the performance assessments that are in the general NASM textbook. You've got that Davies test, right? Reaching across, touching hand to hand. You get the shark skill test where you're jumping from box to box to box. You get the 1 rep max assessment on the bench press. You get the 1 rep max assessment on the barbell squat. Now, there are way more. There are way more, especially in this sports book. In fact, I'm going to pull this up real quick and just take you to this chapter so you guys can kind of see this. Scrolling past my picture too fast. Sorry, this is just for me. All right, yeah, transitional, I guess. I swear in the corrective book it's the other way around. All right, scrolling. Okay, so take a look right here. There's that Davies test. There's the bench press test. Now, here's a special one. And what's kind of cool about this, and one of the coolest things, if you decide to get into coaching, in just a second, I'll take you to the back of the book. In the back of the book, they have specific programs and recommendations for athletes in specific sports. And one of the things that they do in that category, they break down which assessments are most important. The Davies test is a great assessment to assess, how's your client's shoulder stability, right? We're looking at shoulder stabilization here as they transition from place to place to place, right? So when we're looking at that, we're probably going to use that on any athlete that uses their upper body pretty regularly. Like a golfer, the Davies test is pretty helpful. That's a pretty explosive movement involving a lot of joint motion, right? Baseball players, oh my God, do they need shoulder stabilization. So if they struggle on that Davies test, that means that they're struggling with core strength and shoulder stability. So here are some really cool assessments that are in your textbook. For core stability, there's what's called the double leg lowering test. This is actually kind of a fun one. You actually need a blood pressure cuff, which you guys have in your bags, but it's kind of a fun one. What you do is you actually pump your blood pressure cuff up to 40 millimeters. So you pump it up to 40 and then lock it in place. And you place the blood pressure cuff under your low back, right around your L4, L5, so just barely above your pelvis, right? Your L4 and your L5 are the bottom two lumbar that you've got before it becomes your sacrum. So you just push that just below the low back there. And then what you do is you raise your thighs to a right angle, 90 degrees, and then they're going to lower their legs. There's the double leg lowering assessment. They're going to lower their legs, and all of a sudden, at some point, they're going to push their low back into the ground. As their core has to use more and more, and the lower their legs get, what will happen is they'll push their low back into the floor, and that blood pressure cuff's there. And you're looking at the reading, and all of a sudden, if you notice that the blood pressure goes from 40, and it just goes wham, and the needle spikes all of a sudden, that's where all of a sudden their abs are no longer controlling the lowering of their legs. Now what's happening is their low back is trying to push into, and so that's showing you where they struggle with their core stabilization. So, if they experience that at the top, and then obviously, even just holding their legs up at 90, that shows a lack of core strength. But if they're able to lower it all the way down and they never put any pressure on that blood pressure cuff, it's okay, you've got the strongest core ever, this is a pretty rough assessment. I personally hate this assessment, especially because it's you kind of need to have a little bit of hamstring mobility there. There's also the Sorensen erector spinae test. This is kind of a fun one. You have your client lay on their stomach, and they are going to just lift their chest up off the pad you're looking for hopefully 30 seconds. They should be able to do this, and then they can leave their feet down. But they should be able to do this for 30 seconds uninterrupted. They can't hold it very long, or they can't get their spine erected very well. That's going to show weakness on that low back. So we can use both of these for core strength. You know, we've got the front for the abs, and we've got the back for the erector spinae there. This is the STAR excursion test. It's a balance assessment. So what he's doing is he's reaching out as far away as he can. Notice how there's like a bunch of, here, I'll zoom a little bit. See how there's like a bunch of like little individual lines? The further he can reach away, the better balance he has. So that's kind of a fun one. This is very similar to the shark skill test in a lot of ways. I think this is easier than the shark. I think this is where you would start, and then you can move to the sharks test. There's the Davies test. We know that one. How many touches can they get, you know, in trial 1, trial 2, and trial 3. Now, strength assessments, there's the bench press. Strength assessments. Now, there is one special one here. In the NBA, for, you know, like in the NFL, they do a 225 bench assessment. They do as many reps of 225 as they can. In the NBA, upper body strength, not quite as important, so they do the 185 bench press assessment. And it's like, hey, you know, do 10 push-ups, take a 1-minute break, 5 reps at 135 pounds, make sure there's a spotter there, give them 90 seconds of rest. Now, according to the NBA, they are officially warmed up. That's not quite enough warm up for somebody like me, but hey, it is what it is. And then you throw 185 pounds on there and you do as many as you can. And we're looking for what their score is, you know. Lower extremity strength assessment, right? Same concept here. You're going to do, you know, what's your 1 rep max on a bench, barbell squat. Pull-up assessment, right? How many pull-ups can you do? Can you do them with good form? Push-up assessment, how many push-ups can you do? So we see a lot of strength stuff there, right? And take a look, you can see here are also our power cleans, you know, doing a power clean assessment. What's your 1 rep max cleaning a barbell? Which is a pretty complicated movement, but here are our standardized tables that we're looking for females and for males. You know, if you look at like NCAA athletes, right? If you're a male and you weigh, oh, I'm sorry, it's not what you weighed. Yeah, sorry. I thought it's body weight for powerlifters. So if you were able to, like, you know, clean 300 pounds, which, by the way, nice work if you can, you're in the top 90th percentile, you know. Pro baseball players, pro basketball players, right? You know, baseball players, a little bit lower than football players, you know, 265 pounds. Basketball players, 250. So we actually want to see greater upper body strength with a baseball player rather than a basketball player. I mean, they got to whip a baseball and you know, they got to be able to swing a bat like crazy. So we're seeing like some differences here, right? So kind of fun. This is a cool one, the rotation medicine ball throw. Literally, how far can you chuck a medicine ball? This is perfect form, by the way. This girl, I love this picture. She's crushing it. This is better, I think, than the demo that's later in the book. But you can see like both toes are pointing straight forward here. And then like the only thing, she's got a little bit of rotation here externally. Ideally, we keep that leg fairly straight, but like just a great pivot on that back foot. Excellent low back alignment. Like all of this is just awesome. And how far can she throw it, right? This actually, they threw this into, I think the new Army assessment. I think like they've thrown that into like where they redid, you know, the Army fitness assessment. Overhead medicine ball throw, or maybe it was this one. Overhead medicine ball throw, that's literally doing a reverse throw behind you as far as you can. Standing soccer throw, that's literally just chucking as far forward as you can. There's the double leg vertical jump test. You know, standing on 2 legs, leaping up and tagging those plastic markers there. How high can you get, you know? There's a double leg vertical hop too that's doing that on single leg. You don't see this one very often. Broad jump, how far forward can you jump? How far for you know, single leg broad jump, how far can you jump on 1 leg? It should be the same leg. Yeah, so he's jumping with his right and he's landing on his right. Shark skills, we already talked about that. All right, so there is a whole bunch of really fun assessments related to like squatting, jumping, pushing, pulling, you know, all that fun stuff. Then depending on what type of athlete you are training and what type of movements are particularly important for your sport, we've got some speed, agility, and quickness assessments. These are often the same as speed, agility, and quickness drills, but 10-yard sprint, 20-yard sprint, 30-yard sprint, and then, of course, there's the 40, you know, sort of the king of sprinting events out there, you know. 2 cones, 40 yards apart. How fast can you do it? There's also the left test, which is often done as the left drill. You guys will remember doing, well, not you, Charlie, but this is one we'll do when we get to the park. But Robert, you remember doing this one. It's a sprint to the cone, back pedal, side shuffle, karaoke, sprint. So I love watching the left test. Is it? It just doesn't feel like, I'm looking at it, I feel like that's not 10 yards. It's definitely not 10 yards. All right, well, here it is though. So he's going to sprint, sort of, considering it's no space, he's not going to sprint. Back pedal, he's going to turn and side shuffle. Oh man, he's going to turn and side shuffle. He's going to karaoke. So he's doing that little grapevine technique. And then he's going to sprint one final time. And what you do is you tag it at the cone there. So you start the timer, and you're just looking for improvements. You know, how fast can somebody do that over time? That's a really great assessment. This one's pretty much applicable to anybody. The left test kind of applies to pretty much every sport out there. The 5-10-5 test is a fun one. That is actually where you set 3 cones up 5 yards apart from each other, so 10 yards total, and that is a sprint. So they have to like do a touch on each cone, right? So 3 cones, 10 feet apart. I'm sorry, 10 meters apart. And what they're going to do is they're going to face that middle cone, sprint to cone number 2, sprint to cone number 3, and then all the way back to cone number 1. So they're going to touch, and then all the way back. That one's really fun, but a much more famous one that you guys have probably seen or done if you've ever played sports is the 5-0-5 drill. It's actually pulled up here, which I wanted to just show you. This is awesome. This drill rocks. It's so fun. Oh no, please, I just want the video. Oh, you suck. All right, YouTube. 5-0-5 agility test. There we go. There's so much technique involved in this. Like you have to learn how to drop low and transition. It's so fun. But here we go. 3 cones, same thing, but in this version, rather than touching and then sprinting all the way back like that, this one's actually going to start you in the middle. He's going to go over, sprint, run over and sprint, and then the test actually ends when he gets back to the middle cone. So you as the timer, you know, you're going to see him continue to run. What you doing there, buddy? He's in the wrong spot. Of course I pulled up a video that's not proper. Of course I did. Why wouldn't I? Yeah, that's not the assessment. Good job, stupid YouTube. Oh my God. That one? No. All right, I'm never gonna find it. All right. Oh God. All right, start in the middle. It's so frustrating. Start in the middle, sprint all the way through, and then you sprint back to this first cone and you end it there. That's the great. We'll do it in person and then we'll be happy. God, I'm frustrated with these videos this morning. All right, then we've also got like, this is kind of a fun one, the 7 30-meter sprint test. This is tough. This one's like really brutal. But what you do is you're going to do 7 30-meter sprints pretty freaking quickly. And so like you have this set up as sort of a loop here. 10 meters here, 5 more meters here, and they literally are going to turn around the cones. So they're going to go 1, and they're going to go back 2, 3, 4, 5, 6, and 7. And it's going to be very explosive, very fast, but also involves like a lot of turning. So that's actually like rotational rather than, straight line turns. So anyway, there's a lot of these. I actually probably shouldn't spend all this time. But there's the 3/4 sprint drill from basketball. If you've ever done that, it's basically the 40 version for basketball players, sprinting 3/4 of the court. There's what's this one called? The lane agility drill, and that's literally going to be sprint, side shuffle, back pedal, side shuffle, and they're going to go around the court a couple times. T drill, this is one of my favorites. You set up 3 cones and you do a sprint, side shuffle, karaoke, side shuffle, back pedal. So sprinting, side shuffling, twisting all the way, side shuffling again, and then back pedal on the way back. Really, really fun one. We'll do that one in the park as well. It's one of my favorites. This one's brutal, the 300 shuttle test. This one sucks. And it's literally like, you've got 2 cones that are 25 yards apart. This gets very aerobic, but it's 6 reps, back and forth, back and forth, back and forth. It's kind of like a shuttle. It's a shuttle run essentially. Then there's the 20-meter shuttle. This is the pacer test. You guys might remember this one. The beep test is more commonly known as, and where you're going to run from cone to cone, and the beeps are going to get faster and faster and faster. What's cool about the beep test is it can actually be used to estimate your VO2 max. So I actually really like this assessment, and you can do it in a really large group setting. Like you can just tell people like what round they're on, and you can have 20 people do it, 30 people do it, 40 people do it all at the same time. And every time somebody drops out, it's like you're on round 16, you're on round 15, and you can tell people when they drop out, and then you can use that. They can look at a chart, see what round they were on, and use that to determine their VO2 max, or estimate their VO2 max. So there's the scores for those. It'll tell you your VO2 max. All right, 1 mile run. That's a cardiorespiratory assessment. That's performance. That one's the easiest one. Run a mile. How fast you go? Great. Did you go fast in the first time? No? All right, let's start working on your cardio more. So we saw a bunch of assessments. Some were related to stability, some were related to strength, some were related to power. A lot, I spent too much time on, were related to speed, agility, and quickness, and some were related to your cardio conditioning. And we're going to see a couple pictures of those here on the PowerPoint. So there's the stability assessments, right? Star excursion, Davies test, erector spinae test, double leg lowering, strength assessments, bench, squat, pull up, push up, power assessments, all the throwing, like the jumping, right? The overhead throw, the reverse throw, the rotation throw, the double leg jump, the single leg jump, the broad jump. And then we saw a lot of like SAQ ones, right? 40-yard sprint, left test, 300-yard shuttle, 5-10-5, 5-0-5, the 30-meter sprint test, T-test, all those. And then there's the classic cardio assessments. Now, actually, I forgot to mention, they're saying Harvard step test. Here's the YMCA 3-minute step test as we know it. The pacer test, that 20-yard shuttle test, and then a 1 mile run. All of those are cardio assessments as well. All right, any questions on those? I wanted to kind of show you a lot of those. I think I overdid a little bit, but like I wanted to show you guys all those because we're gonna do some of those drills out in the park. And you can test yourself and look, you can do those on your own and look for improvements. I love putting myself through like a fun sports assessment day, You just have to have a little stopwatch and do it as you're jogging. Charlie, Robert, you have any questions on the assessments chapter?
No, I'm good. I'm good, Brett.
Doing good, Robert?
Yeah, so if we decided to ever get our PES, we would have to learn all of those assessments?
Not really. You got to remember, so here's the thing. They reserve the right to ask, if you want to get your PES assessment, right? Because it's in the book, of course, they reserve the right to ask you a question about anything, right? Any sentence in the book, because it's in the book, right? But at the same time, you got to remember, like, this is a test made by people. And And so like you gotta like figure out like which questions are gonna make good test questions, you know. Them asking you how many meters is on like a 505 drill. I mean, that one's in the name. Five, three cones 5 yards apart. So you could figure that one out on your own. But like knowing every single solitary one of those is not something that like makes very good test questions. So I don't know how to 100% answer that question. Like, do you need to know it? Theoretically, they could ask you, but I've never seen anything other than the most common ones. They might ask you something like, which of the following assessments is best for determining upper extremity strength? And it would be the 185 bench press assessment, the left test, the 505 drill, or the 1 mile run. And it's like, obviously it's going to be the bench test, So I'd say know the categories, know their purposes overall, way more so than you need to know every single in and out of every single assessment. I mean, look at how many of I've taught this class a million times, and look at how many of them I don't have, the meters and stuff memorized. So yeah, my answer is yes and no. Theoretically, yes. Practically, no. Does that help?
This would be if we would want to get certified as what, Brad? I'm sorry.
That'd be if you want to get this PES certification.
For sports performance?
Mm-hmm.
Okay.
Yeah. Remember, this is a sub-certification. It's not like this. If you got only this, it wouldn't qualify you to work in like a gym. You need a CPT. That's the main certification. That's also why this assessment, like you take this at home. Whereas your big CPT, you take that at what's called a proctored facility, where you go in and like a test proctor makes sure that you don't have anything in your pockets, you're not looking anything up. They watch you. You have a limited amount of time. The PES test you take at home. So if there is like ever a moment where you're like, how many meters, you can literally Google it or pull your book open. And do it that way, pull up your notes, pull up your PowerPoints, whatever. That's why, because they allow you to do that, that's why it's a lower tier. It's not on the same level as the regular CPT. Robert, do you have any more questions?
No, that was it.
Cool. All right, let's look at flexibility. So Charlie, it's official. We're gonna finally talk about how many reps and stuff. So this is how we write flexibility programs. This is how we write our warm-ups. All right, so our objectives today is we want to understand muscle imbalances and how they affect the kinetic chain, why flexibility training is important, different types of flexibility techniques. So there is more to stretching than just like there's more to stretching than just long, slow stretches, right? And then we want to be able to, perform the right version. So first, we're going to do just a very brief kinesiology review where we talk about like muscle imbalances and why we need to avoid them. But when it comes to muscle imbalances, right, we got to remember that like in order to maintain proper range of motion, like if we define flexibility, right, flexibility is defined as the ability to move a joint through its complete range of motion. If you have a tight muscle on one side and a weak muscle on the other, you're not going to be able to move that joint through its complete range of motion. It's going to get trapped somewhere because the bone doesn't move the way it's supposed to. So we need to be able to maintain ideal posture and avoid muscle imbalances. Now, what causes muscle imbalances are sort of these three main concepts. So first, I want to review, I always do this whenever I'm talking about this, but we want to review like what reciprocal inhibition is, right? If we talk about like how our body is supposed to move, your body is arranged, muscles can only pull. Muscles can't push. They can only shorten and then they can relax back to their original length, but they can't push in the opposite direction. So, if that were true, I mean, that is true, but imagine if I only had biceps and I didn't have triceps, right? I'd squeeze and I'd be stuck like this for the rest of my life. Like, well, I've used my one elbow bend for my lifetime, but luckily that's not how our muscles work. Luckily, I've got triceps to pull me back the other way. So all of your muscles work on this sort of pulley system, right? One this way, one this way. And so then in that arrangement, when you activate one muscle, your nervous system is designed to let go of this muscle. And when it activates this muscle, it's designed to let go of that muscle. That arrangement is called reciprocal inhibition. One muscle reciprocates the other one, right? Just in the same way that you and your significant other reciprocate each other, when, maybe you're in a fight and then eventually it comes down to, you know what? You're right and I'm wrong. That's reciprocal inhibition. I am inhibited in response. So it's a physiologic process whereby an agonist contracts that antagonist, it's going to relax, right? Now, that doesn't always happen, or at least doesn't always happen the way it's supposed to. And that's where we get altered reciprocal inhibition, jacked up reciprocal inhibition, not good reciprocal inhibition. And that's where you get a tight agonist that refuses to relax. And so it's actually pulling in the opposite direction. And that decreases the neural drive. Your nervous system can't activate its antagonist anymore the way it's supposed to. So a tight or overactive hip flexor might decrease the strength of your glutes, causing an anterior pelvic tilt, or maybe just causing a loss of glute strength. And so that's altered reciprocal inhibition. Now, when that happens, your body still, you still want to do the job. You still want to squat. You still want to do whatever it is you're doing. So then we start to experience where a synergist might come in and take over for the job. It might instead try to do the work of that inhibited muscle. And so then we get synergistic dominance, where a helper muscle comes in and starts doing more work than it's supposed to. So a synergist takes over for a weak or inhibited prime mover. So now, because that gluteus maximus is being inhibited by your hip flexor, your gluteus maximus can't do hip extension the way it's supposed to. So then your hamstrings come in and do all the work, right? Now, what that's going to lead to is you moving in a way that, like, you kind of moved you kind of got the job done, but you didn't really move the way you're supposed to. So we start to experience what's called relative flexibility. It's like, yeah, you got the job done, but that's not really how we're designed to move, So now you're putting too much stress on certain muscles, you're putting too much stress on certain parts of the joint, and it can be kind of painful, right? So it's a process by which the body finds the path of least resistance during a movement. That puts too much stress on certain bones and leads to arthrokinetic dysfunction. Arthrokinetic is, remember, arthro stands for like joints and bones. Kinetic stands for movement. So this is joint movement dysfunction. Your joints move in a way they're not supposed to. So the biomechanical dysfunction of two joints that leads to abnormal joint movement. Now, I should say, a lot of times I do kind of teach this in like step by step by step. It's like you get a tight muscle that inhibits the opposite muscle, then the helper muscle takes over. That doesn't necessarily always have to happen that way. You could just have bad habits, and then a tight helper muscle can take over. That sometimes happens too. A lot of times it's on the opposite side of the joint. Sometimes it can be on the same side of the joint with a helper muscle. just a synergist takes. A good example of that is like, me right now, like I'm talking and I'm sitting, into this shoulder. My upper trap is, in a shortened position over here. So now maybe if I were to go do some rows or something, I would maybe pull my shoulders like this instead of, keeping them pinched down and back. And it's like this helper muscle is taking over, even though no opposite muscle is affecting, this muscle back here. So synergistic dominance can occur without reciprocal inhibition, but a lot of times they're associated. A lot of times that's why we see these lists where we kind of do this zigzag thing. So in order to understand all that, we're going to just very quickly review our anatomy. When we look at the structure of a muscle fiber, the reason all of this is happening, that this tightness is occurring, is because like your muscles are in a shortened state. We look at like inside an individual muscle cell, right? So we've got a muscle cell here, and inside that muscle cell, you can see all these overlapping myofilaments, right? You can see the little thin filament here. That's your actin strand. And what's supposed to happen is this myosin strand, this really thick filament, has all these little heads on it. It's supposed to reach up and grab that and pull this little blue line right here, which is called the Z line. It's supposed to pull this way, and this one's supposed to pull this way. So what ends up happening is that muscle cell goes from being this long to being that long, and then it can relax, right? The area where that happens, we call that the sarcomere. So the sarcomere here is going to shorten in response to a muscular contraction, or I guess to cause a muscular contraction. So you've got actin, which is the thin filament. It's got all these little binding sites that myosin, which is a thick filament, wants to reach up and grab, and they're going to pull everything in close. Now, obviously, we don't want that to happen all the time, right? We don't want that to like always occur. So because we don't want that to constantly occur, we have regulatory proteins, the troponin, the tropomyosin, they're there to block those actin strands. They block the actin's binding sites. And so that keeps these heads from reaching up and grabbing when we want our muscles to relax. But if you have got an overactive muscle, your nervous system is basically sending a signal all day, 24 hours a day, to keep that muscle in a shortened state. It's like, nope, we're just going to hold this tension right here. And so like those binding sites are basically always open, and those regulatory proteins never get back in place. That's one of the reasons that causes like a tight muscle. There can also be things like scar tissue. You know, if you pull a muscle, tear a muscle, something like that, experience some type of trauma or damage, you can get inflammation, and then your body's like, we got to repair this, and so it puts super glue over everything. Now you're stuck with scar tissue, and so now you got to break up that scar tissue. That allows that to get its mobility back. So, you know, it's not always a nervous system problem. Sometimes it's a muscular system problem, but either way, it's in a shortened state and it's staying there. So we need to break that up and get that back to a lengthened state. But we also don't want it to an over lengthened state, right? We don't want to end up where like there's no grip between the actin and myosin, because now we're going to have trouble contracting. Looking at a muscle cell, looking at an overall muscle structure, you know, your muscles are layers of layers of layers, all of these individual muscle cells all bundled together. So you've got a muscle cell, and then that muscle cell is bound together with like a bunch of other muscle cells. We call that bundling action, we call that a fascicle. So a fascicle is a bundle of muscle fibers, and then that fascicle will be bound together with other fascicles that will come together to make up your overall muscle. So a muscle is a bundle of fascicles, a fascicle is a bundle of muscle cells, and a muscle cell is a bunch of bundles of, you know, little myofilaments, actin and myosin. Those are all the terms. We kind of already moved through those. Now, understanding how your muscles work, don't forget, guys, your muscles can only either contract, or I'm sorry, you're not your muscles, but your muscle cells, each individual cell, when it gets stimulated to contract, it will always contract 100%, or it will not contract at all. There is no in between. Your muscle cells do not have the ability to contract for 50% max strength. So when we look at that, right, that's called the all or nothing principle. When a muscle fiber contracts, it either contracts all the way or not at all. So, you know, if you think about it, I have no idea how to Google this image, so I'm going to draw one. I apologize because I know my drawings are crap. Copy, paste. Hey, copy, paste. What the? Kidding me right now? Oh, I needed to deselect. That was the problem. Put that one there. And, oh my God, stop. I just realized, what am I doing? I can very easily do this. I can copy what I've already made and then finish the job much faster. Okay, so these are all individual muscle fibers, right? You know what? And just while I'm at it, we're gonna make this way bigger. So I don't know, what do we got? 1, 2, 3, 4, 5. I got 20 muscle fibers here, right? So let's say I create like a really strong contraction, right? Like, and we'll color our muscle fibers here real quick. So we're gonna keep red means that they're turned off. Okay, red means stop, right? So these muscle fibers are not contracting. These are relaxed. Every one of these muscle fibers is relaxed right now. But let's say it is time for me to, get up in the morning. I wake up and I get out of bed, right? So I lay my feet over the edge of the bed, knees are bent, and then I squeeze and I go up into a standing position, right? Well, that standing position, that's hip extension, right? I'm performing, coming out of a squat, basically. So, I can barbell squat a pretty substantial amount of weight, way more weight than it takes me to like get up out of bed in the morning. So according to the all or nothing principle, our muscle fibers, when they contract fully. So how do I control, how is it that like when I get out of bed in the morning, I don't spring up and jump as hard as I can? It's not that you contract your muscle 100% every time, is that you contract individual muscle fibers 100%. So maybe I contract this fiber and this fiber and this fiber, and that was enough to get me up out of bed, right? Then let's say I start doing some like body weight walking lunges, right? Walking lunges are obviously putting a little more stress than just standing up out of a chair. It's a little bit more because my legs are split. So now I'm putting a greater distribution of weight on one leg at a time. So now I'm recruiting more muscle fibers. Maybe now I'm recruiting all of these, right? And then after that, let's say I'm going to go over and get under a barbell, and I'm going to do a 1 rep max, almost as heavy as I can, and squat as much as possible. Well, that means that I'm literally going to contract every single one of my muscle fibers. Now all of them are turned on, right? So that is how your body controls its contractions. And I'm bringing this up today in the flexibility chapter, but this concept is going to come back really, really importantly when we talk about max strength. Because how do you train for max strength? Like based on what we just said, and Charlie, you're the newest here, so I'm going to pick on you a little bit. But like if based on what I just said, if I were to ask you to figure out a way to get your body to train for getting better at max strength, how would you do that?
How as in like you talking about like hypertrophy and like all that? Or
Not so much hypertrophy, because that would be muscle growth. I'm talking about like if I wanted to get better at squat, I want to lift more weight. What principle do you think is going to be a very important concept?
They're like the 1 rep max, or
Yeah, I'm going to lift at a high percentage of my 1 rep max, right? Pretty close to maximum. And
right.
why do I need to do that? Because the all or nothing principle states that I need to get all of my muscle fibers to contract, all of them, rather than just Bob, Terry, and Joe. Like I want the army of muscle fibers contracting, not just a couple of them.
Right.
And that's the difference, right? That's how we can pick up a super heavy barbell, and then we can go pick up a kitten without flinging it into the air. That's how we are able to control our strength. If we want to have like a weaker contraction, recruit less muscle fibers. Want to have a strong contraction, recruit a lot of muscle fibers. So stabilization routines don't recruit as many muscle fibers. They still result in muscle growth, right? But like they're not recruiting as many fibers. That way we can perform them under like a long duration. Whereas if I recruit all of them, they're going to get tired pretty quick. And that's why we have high reps versus low reps. And when we're doing low reps, we're doing high weight. They work backwards of each other. Now, looking at connective tissue, because we are talking about flexibility today, not strength, we have our tendons. Tendons are what are going to attach your muscles to your bones. And then we got ligaments. Those are going to attach your bones to your bones. Ligaments can get tight. Tendons can get tight. Muscles can get tight. One of the things that we tend to see in like a lateral ankle sprain, what ends up happening is you damage this lateral ligament right here. You roll your ankle, that overstretches this ligament right here and tears it, right? And now, by the way, this ligament's drawn in red. Normally we draw them in white. There we go. So, that ligament gets damaged, and then your body's going to try its best to repair it. But like, how does your body repair tissues? It does it with scar tissue, it builds this like thick fibrous connective tissue. That's in the skin, but let's take a look at like on a muscle, right? It would look something like this. Well, now that ligament is not quite as mobile as it used to be. And so because that isn't as mobile as it was, the bummer there is that we need to increase that mobility. So tendons need stretching through full ranges of motion the same way ligaments need stretching through full ranges of motion the same way muscles do. All of those tissues, when they tear, are going to result in some version of scar tissue. A lot of people have this misconception that scar tissue only exists in muscles, and it's like you have a scar somewhere in your body, right? Like literally, like on your hand or something. Like that's scar tissue. Like, it's just when your body repairs, it can't, they can't repair it perfectly. So this is one of the reasons why we have to talk about, when we talk about like how, actually, hold on. I want to continue talking about scar tissue, and I need to with this, but I do really quickly want to just get through the neuroanatomy real quick. So remember, your central nervous system is controlling all of these contractions, right? Your central nervous system relays the information to your peripheral nervous system. Your peripheral nervous system then leverages the resources necessary to, contract a muscle. And it does this through the use of neurons, which are the, cells that are running throughout your body that zap your muscles to make them contract. Obviously if you experience like some type of like injury or something, trauma is going to initiate the nociceptors, which are your pain receptors, to cause you to relax. That can or contract, like if I overstretch my bicep's going to contract back the other way. It's going to go, oh, holy crap, you overstretched me. And it's going to pull back because a shortened state is nice and protected. You can't tear something if it's like folded, when it's all the way stretched out. That's how it gets torn, and so that can cause like a little like spasm. And then now that muscle never wants to let go again. It's like, no way, last time I got stretched out, you tore me, right? So I'm gonna stay like this. And so you're trying to coax those muscles back to full length. Really quickly, where's Davis's law? There, okay, it's coming up. So as we get older, this is going to happen. We experience this, over the course of our lifetime. And so as we get older, we can experience two different things that can happen in your muscles. We can experience atrophy, which is literally a shrinking of your muscle fiber size. That's something that happens as we get older. There's also sarcopenia, which is a decrease in the number of muscle fibers. So like literally having less muscle fibers. If you immobilize a joint, that's also going to cause, like if you break a bone or something, you're stuck in a cast or in a sling or something like that. That's also going to decrease your mobility. Basically, we're looking at all of these things. That's reducing how mobile your muscles are, right? So a lot of this is talking about a lack of range of motion. We lose our elasticity. We lose our plasticity. Elasticity is the fact that your muscles are kind of springy. Viscoelasticity is the fact that your muscles are kind of gooey. And then plasticity is the ability to like your muscles either change in length and they kind of stay that way, either short or long. Our ability to improve our flexibility is thanks to plasticity. It's relatively permanent changes over time. Now, why does all that happen? Why does scar tissue make us less mobile? Why does increases in mobility over time happen if we continue stretching ourselves out? Well, there's a couple laws that kind of explain this. One of them is Davis's law. And Davis's law is something that I used to spend a lot of time talking about. Honestly, NASM kind of breezes over it. And I get it. Like, it's not a very practical thing that you ever have to talk about with your clients, but it explains why we do so much of what we do. Davis's law states that soft tissue will model itself along the lines of stress. You understand why I like this so much, because this sentence is basically saying function follows form and form follows function. They are totally interlinked together. If you move a certain way, the soft tissues will model themselves to move that certain way. Why are you mobile? Because you stretch a lot. Why are you immobile? Because you don't stretch a lot. It's honestly pretty simple, right? Whatever stress you place on the body, your body will model itself along that type of stress. Function follows form, form follows function. I didn't actually know that I had that sentence here. That's hilarious. Past Brad and future Brad think alike. Shocker there. Now, same concept that's very similar to this, but talking about hard tissue. You also have Wolff's Law, double F. Bones in a healthy person or animal will adapt to the loads that they are placed under. Your bones will do the same thing. Break your bones a little bit, and I mean microfractures, not full fractures. Guess what? Your bones are going to get harder and stiffer and more resistant to that damage. So Davis's law and Wolff's law state why it's so important for us to perform flexibility training, right? Why it's so important for us to exercise regularly. Because we do not want to experience this, the cumulative injury cycle. You do not want to have some type of tissue trauma, which leads to inflammation and a muscle spasm. That leads to scar tissue, which leads to you not being able to move your muscle through its full range of motion, or ligament through its full range of motion, whatever. And that's going to screw up how you move your body. You're going to have altered control. That's going to lead to a muscle imbalance because now some other muscle is going to have to take over. And guess what? Muscle imbalances lead to injuries. And that's an evil cycle that continues over and over and over again. We are going to take advantage of Davis's law and Wolff's law when we are exercising, and we are going to use our nervous system to hack our way to more mobile, joints. We're going to hack our way to being able to move the way we're supposed to. We're going to use Davis's law, that modeling along the types of stress, to get better at stretching and having the ranges of motion that we want. What range of motion do you want? You want to be able to move your hips better? Let's stretch out, So there's a couple different principles that we're going to use here. One of them is the myotactic stretch reflex. That's basically a stretch reflex. When you contract really fast in one direction, your muscles will naturally want to spring in the other direction. We're not talking a ton about this today. This is really going to come up much more when we talk about we'll talk about it today with dynamic stretches, but this is really much more of a reactive exercise, kind of explosive concept. It's the stretch reflex, right? But one thing that we're definitely going to spend a lot of time talking about is autogenic inhibition and reciprocal inhibition. So reciprocal inhibition, again, that thing we talked about earlier, contracting one muscle to cause another muscle to relax. But one of our other principles that we've got is autogenic inhibition. And this is one of our most important concepts. NASM loves to test you on this concept. They love to ask you questions about this. But what autogenic inhibition is it's this really cool physiologic response where if you put a lot of pressure on a Golgi tendon organ, it will actually inhibit a muscle spindle. So in your muscles, remember, the way your body knows where it is in space, the way it has proprioception, is because it's got Golgi tendon organs and muscle spindles, right? And muscle spindles are there to tell your brain, hey, my muscle's at 80% max length right now, 90% max length right now, 50% max length right now. It's there to tell your brain how stretched out the muscle is. Meanwhile, the Golgi tendon organ is there to tell your brain, hey, here's how much tension's in the muscle right now. Here's our likelihood of getting pulled off the bone. Right now, right now my pecs are in a shortened state. I can't really, bring my pecs any closer together. They are as short as they can get in this position right here, right? Well, if that's the case, the amount of tension on my Golgi tendon organ, low, right? There's barely any tension there because it's not being stretched out. The odds of it getting pulled off the bone are slim to none. But if I bring my arms way back like this and I stretch my chest out, now, my muscle's being pulled end to end. And so there's a lot of tension, right? So that's what muscle spindles and Golgi tendon organs are. The muscle spindle is running through the length of the muscle, and its job is a sensor receptor responsible for sensing changes in the length of a muscle and the rate of those length changes. Golgi tendon organs, they're in the tendon. They're there to sense the tension in a muscle. How long is the muscle? How likely is the muscle to get pulled off the bone? Right? That's what we're looking at in these two sensory receptors. So they're working together, right, to make sure that you don't pull your joint through a full range of motion. Now, if your muscle's really tight and it's squeezing, right, and then you're also trying to stretch, so you're pulling it apart, but it's tight at the same time, that's putting way more tension on that Golgi tendon organ, because now the Golgi tendon organ is not only trying to hold over here, it's also trying to be contracted over here simultaneously. So it's just creating all this tension, and eventually, you know, it's going to lose its grip, right? So the Golgi tendon organ is going to do this really cool trick. If you put pressure on it for 30 seconds, which can, by the way, be like by literally pressing through like massage, or maybe using a foam roller, right? If you put pressure on it by either pushing on it like I'm doing right now, or if you put pressure on it by stretching it through a full range of motion, right? Either way, when you put pressure on a Golgi tendon organ, what's going to happen is it's going to start to kind of freak out because there's a high level of tension. It doesn't want to tear off the bone. So it's going, wah, 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 right? Meanwhile, the muscle spindle is also freaking out. It's like, hey, no, we're at, you know, we can't go any longer. We're already at full length. Now, we know this isn't true. Like, that muscle can totally stretch out a little bit longer. Muscles are very bendy. But the muscle spindle is always trying to protect itself. It always wants to like stay in a shortened position. So when you put pressure on that Golgi tendon organ, both of them start to freak out. And what's going to happen is the Golgi tendon organ is going to go, all right, nuclear option. This guy's still stretching, and if I keep holding like this, eventually we're going to tear off the bone. What we should do is just relax everything. Turn everything off. Give him what he wants. Give him the full range of motion, right? It's like, you know, it's a hostage situation gone bad. So autogenic inhibition is this physiologic process whereby your nervous system will inhibit your muscle spindle because you put pressure on that Golgi tendon organ. It says, if you're going to keep stretching and I have no choice, I'll give you the mobility you want. And so that muscle spindle gets inhibited because the Golgi tendon organ says, hey, shut up, let go, you know, and then it lets go and you get your full range of motion back. Then your nervous system goes, holy crap, we had way more range of motion. And you learn that, your body learns that, your brain learns that, and hopefully it retains that and says, and next time your muscle spindle's like, no, we can't possibly stretch out any further, your brain's gonna go, just an hour ago, you were this long, relax, you know? So that is autogenic inhibition. You put pressure, what you need to know is you put pressure on a Golgi tendon organ and it relaxes an overactive muscle spindle. Now the other process is when you contract the antagonist muscle. Let's say you contract that opposite muscle, that's going to create reciprocal inhibition. When I contract my upper back, it will tell my chest to relax. When I contract my quads, it will tell my hamstrings to relax. When I contract my bicep, it will tell my triceps to relax. Anytime you contract one muscle, the muscle on the opposite side of the joint is organized in such a way that it's supposed to relax. So those are both physiologic principles that happen inside our body, autogenic and reciprocal. There is also the myotactic stretch reflex. Stretch reflexes, which is actually not on this list right here, but when you rapidly contract a muscle, that muscle freaks out and then it contracts in the opposite direction. You know, you pull really hard this way, you naturally kind of pull back in the opposite way. So all three of those are principles about how the body, you know, your body just works that way. It just does, right? So if we know that that's how the body works, NASM has created a model for how to take advantage of each of those physiologic principles separately. And that is where we get our program design from. So here it is. When you are writing a program for a client in stabilization, right? So if we look at NASM's OPT model, right? You're going to break your clients into 3 levels. Stabilization, and that's the only thing we're talking about today. We're actually not talking about phases today. But if we're looking at stabilization as a level, strength as a level, and power as a level, we want to make sure that we're going to use one of these physiologic principles. We are either going to use autogenic inhibition, reciprocal inhibition, or a stretch reflex. So which one should we use for which clients? Well, if your client's in the stabilization phase, there's some other rules that kind of come along with that. When we get later down into the program designing, we've got, you know, we're going to do a high number of repetitions. We're gonna lift at a relatively low intensity. The whole point of stabilization is to build a foundation for your client that they can build upon later. So, do I need someone to be explosively flexible if they're a beginner? Not really. What I need is to fix their muscle imbalances. I need to take their muscles that are too short and I need to get them back to full length. So we have corrective flexibility. So Charlie, this is sort of the key nugget you need to know today. So when it comes to clients in stabilization, the type of flexibility that we're going to focus on is called corrective flexibility. So that's a category. Stabilization clients get corrective flexibility. Now, think of corrective flexibility as a tool bag. Like, what tools are in my corrective flexibility tool bag, right? I've got a corrective flexibility tool bag for my stabilization clients. I've got an active flexibility tool bag for my strength clients, and I've got a functional flexibility tool bag for my power clients. So if my client's in stabilization, I grab my corrective flexibility tool bag. What tools are in there? Well, one of those tools is foam rolling, self-myofascial release, right? Using a foam roller to gently put pressure on a Golgi tendon organ to get that muscle spindle to relax, right? So I'm going to apply a little bit of autogenic inhibition with foam rolling, right? Autogenic inhibition, pressure on a Golgi tendon organ, right? So we're going to use that in corrective flexibility. So corrective flexibility consists of that as one of our tools. Also, static stretches. Static stretches are they're what people think of when they think of stretching, right? They're the long 30-second holds, right? Boom, hold it, count for 30 seconds, 30 seconds later, that muscle relaxes, right? Static stretches and self-myofascial release are both taking advantage of autogenic inhibition. They're doing it in slightly different ways. You know, self-myofascial release is poking a Golgi tendon organ. That causes the muscle spindle to relax. Static stretches are pulling on a Golgi tendon organ. That causes a muscle spindle to relax. So corrective flexibility is used for correcting muscle imbalances. That's its primary purpose, right? Which is definitely something we want to do in our foundation. Now, there is one more category here, which is called PNF stretching. It's also more commonly known as neuromuscular stretching. PNF, it stands for proprioceptive neuromuscular facilitation. This is actually a pretty advanced technique that you guys aren't going to learn too much of in the core. You're going to learn this in capstone with Mo. But what PNF stretching is it's actually sort of blending the line, it's blurring the lines between autogenic and reciprocal inhibition. It actually uses both of these simultaneously. You've probably done this if you've ever played sports, but what it is someone would contract, you would like, actually can't really do it like that. I'll do this. So you would take yourself into a stretch, right? Or someone would take you into a stretch. And you would hold that for 20 to 30 seconds, right? So there's your autogenic inhibition, right? You're doing autogenic inhibition because you're doing a long, slow stretch. But then if I were to try to drive my heel into the floor, so I contract my hamstring, right? See how I'm like contracting it and I'm pulling it down, right? If I drive it into the floor and I contract it for like 7 to 15 seconds, and then I relax and I see if I can get a little bit of a larger range of motion, that contraction is creating reciprocal inhibition, right? Reciprocal inhibition is something that usually we use later on, but I'm kind of getting the best of both worlds. I'm blending them together. That's neuromuscular stretching. So like I said, you're going to learn that technique with Mo, but for now, I want you guys just to focus corrective flexibility. Almost forget this for now. Corrective flexibility is going to consist of self-myofascial release and static stretches. You're going to do both of those for 1 to 2 sets, 30 seconds hold for each repetition. So when you're writing a program for your client, who that client is in stabilization, in here? No. Crap. Hold on one second. There we go. So when you're writing a program for a client who's in stabilization, it might look something like this, right? You would foam roll their lats, thoracic spine, and pec, right? And then you would do a static stretch for each of those, and you would do each of those for 30 seconds. And that is a classic, you know, sort of stabilization routine. Now, if your client is in the strength level, oh, that's right. If your client's in the strength level, right, level 2. So if they're in phase 2, phase 3, or phase 4, all of those are the strength level. That's going to use active flexibility. So now you're not grabbing your corrective flexibility tool bag. You're grabbing your active flexibility tool bag. So clients in the strength level get active flexibility as a concept. What's in that tool bag? Well, guess what? Foam rolling's in there again. Foam rolling, you know, it's a great way to break up all that fascia, break up that scar tissue, you know, bust everything up, get some blood flow to the area. It makes your stretching more effective. So we always foam roll first. But then, because it's active flexibility, now rather than doing these big, long, static holds for my stretches, what I'm going to do instead is I'm going to use reciprocal inhibition, right? Static stretching uses autogenic inhibition, long duration, eventually the muscle spindle gets shut down. Reciprocal inhibition, I'm going to contract one muscle in order to tell my nervous system to relax that other muscle. So what I do is I draw it through a range of motion. That's saying relax, right? And then I draw it through a range of motion, relax, right? I'm going to go 1, 2, I'm going to stretch for a certain number of repetitions. So I'm going to do 1 to 2 sets, just like I did in corrective flexibility, but I'm going to do 5 to 10 repetitions, and each rep, I'm going to hold it for about 1 to 2 seconds. So I go 1, 2, 1, 2, 1, 2. And every time I'm contracting my upper back, that's telling my chest to relax, right? That's active flexibility. And that's what we use for our clients who are in phases 2, 3, or 4, right? They're in level 2, they get active flexibility as a category. So corrective flexibility takes advantage of autogenic inhibition. Active flexibility takes advantage of reciprocal inhibition. And then the power phase really is not about improving your range of motion. It's really not its goal. This is in the power level, your client is at the top of the staircase, right? You built a really strong foundation. You built upon that foundation. Now they are improving their maximal capabilities. They shouldn't have very many muscle imbalances at this point. It should not be that you are worried about their full range of motion. So now they're getting functional flexibility because they're already functional. Now we're just trying to make them improve and get to peak capacity. So you're going to grab your functional flexibility tool bag. The tools that are in that tool bag are self-myofascial release. It's in every bag. But instead of doing static stretches or instead of doing active stretches, now you're going to do dynamic stretches. Dynamic stretches are fairly explosive stretches, right? That move, you contract your muscles to draw your muscles through a full range of motion. So it might be something like this, or arm circles, or scarecrows, right? It's stuff that you're driving through like a full range of motion by contracting your muscles. This is creating that myotactic stretch reflex that I talked about, right? So, what ends up happening here is it's not a really great way to improve your range of motion. Now, you might get some improved range of motion temporarily because you're going to increase your tissue temperature. Your muscles will get a little more pliable. But by being explosive like that, that actually creates more tension in this muscle because it's going, ah! Every time you rapidly stretch it out, that muscle's like, holy crap, I'm getting stretched out. It thinks that it's going to get torn. So you're actually telling it to get better at contracting, which is great because the power phase is all about being super explosive. So this is a great way to turn your nervous system on and get it firing like crazy before you go try to jump super high or throw something super far, So you're gonna do 1 to 2 sets of that for 10 to 15 repetitions. That's going to get your nervous system all fired up. So again, one more review. Stabilization uses corrective flexibility, which are techniques that focus on autogenic inhibition. That's self-myofascial release and static stretches. The strength level, you are going to focus on active flexibility. This is going to use reciprocal inhibition by using active isolated stretches to contract an agonist and hopefully relax its antagonist. Then in the power level, you are going to focus on functional flexibility, which is using stretch reflexes to actively turn your nervous system on. And you're going to do that through dynamic stretches.
I have a question.
Yeah, question?
So I know for all three phases, the SMR is included, but how many stretch exercises do you recommend someone to do?
As many as they need to get to a safe range of motion and move the way they're supposed to. If they've got an anterior pelvic tilt, we know that that's caused by tight hip flexors and a tight erector spinae. So there's a minimum of 2 right there. But the hip flexor complex is both like the rectus femoris and the TFL. So now that's really 3, you know? So that's your call. How much time can you get?
Maybe?
What's that?
So it would be like one stretch exercise for each, maybe, or?
Yeah. They got rounded shoulders. We know that's pec minor, pec major, and lats. So I would focus on all 3 of those, you know? When it comes to all this, right, the techniques that have been shown to really increase your range of motion the best, by the way, when it comes to just improving your full range of motion are neuromuscular stretching and static stretches. So if you have like as little time as possible, but you want to get the greatest bang for your buck, neuromuscular stretching is one of the best ways to improve your range of motion. And the way you do this, right, is you're going to do, and they're saying like 1 set, 30 seconds, 5 times a week. This works really well. There's some new research that shows like 2 sets for 30 seconds has been shown to be incredibly effective, or 1 set for 60 seconds. That's a little bit of new research, but it isn't reflected here. Neuromuscular stretching is one of the best ways you can do things. It gets the advantage of autogenic inhibition because you do a long hold, but it gets the advantage of reciprocal inhibition because you're contracting. So you're kind of hitting it from both angles here. The way that you do this is you do 1 to 3 repetitions. You only do 1 set. 1 to 3 repetitions. You stretch for 20 to 30 seconds. You contract for 7 to 15 seconds, and then you repeat. So, you know, the stretch followed by the contract, that would be 1 rep. So I would maybe hold for 30 seconds, contract for 15 seconds, hold for another 30 seconds, contract for 15 seconds, hold for 30 seconds, and then I'd be done. So that's, you know, and those contractions, by the way, like they don't need to be maximum effort contractions, 20 to 25%. You know, it's not like your client has to like, you know, pull really, really hard. Now, NASM, their position on flexibility, isolated muscles don't necessarily always cause like lack of range of motion. So proper flexibility needs to be addressed on both sides of a joint. If you improve your range of motion by like, let's say I stretch out my chest, that's fine. But if I'm not pulling my shoulders back by strengthening my shoulder blades to, you know, actually keep me in that range of motion, I'm only addressing half the problem, you know? So when we look at like an overactive, underactive muscle, when you look at that muscle imbalance, right? If I loosen this up, I need to pull this back the other way. I need to loosen on one side and strengthen on the other. Otherwise, I'm really not addressing both sides of the problem. It's like I untied my shoelace, but I didn't, you know, I untied the knot in my shoelace that was like screwed up, but I didn't retie it the way it's supposed to be, you know? And so it may just flop right back into that bad position. So NASM wants to make sure that like you know, don't make the mistake that a lot of trainers make where they only focus on flexibility or they only focus on strength training. You really do want to attack both sides of the joint. So always determine which muscles need to be lengthened. Don't stretch the muscles that don't need to be. If you have like an underactive, you know, so many people do glute stretches and it's like, why? What are you doing? Like that's the most underactive muscle in your body. Don't spend any time stretching that before you start working out, you're turning that muscle off before you're trying to go turn that muscle on. That's not a great plan. Now, once your workout's over, sure, if you want to get some blood flow in there to make sure that you're a little less sore the next day, there's some research, not a lot, but maybe that'll help. During your cool down, stretch out the muscles that you exercised. But generally, what you want to stretch is the stuff that's tight, not the stuff that's already loose. This is why I hate the way I was taught gym class, our teacher would teach us 5 or 6 stretches at the beginning of the year, and then it was expected that we would just do those stretches before PE started, and what happened was every kid in there, me especially, picked the stretches that felt good and only did those. Teacher didn't know any better. There's 25, 30 people in that class. So I'd stretch my quads, which didn't need to be stretched, and I was like, oh, but the hamstrings, that's uncomfortable. I don't want to stretch those. And I left them alone. Bad habit. So that is a big important thing to remember. Another one that is just general, we'll talk about this more in later classes. Do not use your static stretches before intense activity. So static stretches do have one negative effect, which is they leave your muscles a little groggy. If you're going to go do some maximum heavy lifting, it does not make any sense to do static stretches beforehand.
Sorry,
that is why, what's that?
What was that? It's because you cut off, so I wasn't able to hear what you said about the static stretches.
Oh, sorry. Static stretches should not be used before maximal strength lifting. It doesn't make any sense to turn your muscles off before you go try to use your muscles. Now, I want to put an asterisk on this. If you have bad range of motion, if you move the way you're not supposed to move, you should absolutely do some static stretches to restore that range of motion. But let's say I'm just trying to promote some blood flow to my chest, right? And let's say I don't have rounded shoulders. Well, it doesn't make any sense for me to do static stretches before doing a 1 rep max bench press day. Because if I do, I just turn my muscles off before I try to use them. I'm going to reduce my strength. And now I'm not going to be as strong as I'm supposed to be. Now you start to see why we do static stretches down here in stabilization, but we don't do static stretches up here in strength. Because this is all about lifting heavy. This is about lifting light. I don't care if I do static stretches before a light chest day, but if I do static stretches before a heavy chest day, I'm going to lose some of my strength. And I certainly am going to lose some power. So we definitely don't do static stretches here or here. Obviously, there is a exception to that rule. If your client has a poor range of motion, you're going to sacrifice the strength. What's important is to move properly. So, sacrifice the loss of that strength. But what we tend to see is about a 7 to 8% reduction in strength. For the sake of argument, just to keep the math simple, let's say you can bench press 100 pounds, right? And then you go do a big, heavy static stretch before you go try to do your bench press. Well, you're probably only going to be able to lift 92 to 93 pounds because you reduced that strength ever so slightly. But that's why we have active stretches. I'm not saying don't stretch. I'm saying don't do static stretches before heavy lifting. Active stretches haven't been shown to have this effect. Dynamic stretches definitely don't have this effect. So that's why we have static stretches in corrective exercise. We have active stretches in active exercise, and we have dynamic stretches in functional exercise. So your overall strength may not be decreased if you combine those stretches with active or dynamic stretches. But static stretching also may decrease your power, which, obviously, strength and power are, brother and sister. So instead, again, use your active isolated stretches or use your dynamic stretches. But there is some other research, and we kind of know this already, but self-myofascial release when combined with all of these types of stretches have been shown to have the biggest effects. So you want to make sure that you're using all of those. Don't just stretch. A lot of people just stretch. Make sure you're foam rolling as well. That's going to be a booster. And then, in terms of using active isolators, if there's no muscle imbalances that exist, then you don't necessarily need static stretches, But the last thing, once your workouts are over, the workout's over, right? So do we care about reducing our strength? No. You can use static stretches in any level of training at the end of your workout. So where's my OPT? So if let's say I'm just gonna, whoops, this is supposed to be blank. That's not good. I'm gonna build an example here actually, no, I have it. Oh, I already have it. Hold on. Switch your resources. Example, 3 months, 3 months. Don't I? Oh, am I crazy? No, hold on. I know I have it. Hold on. Sorry. 1 second, guys. Kingston, searchy stuff, desktop. Okay. So here's a level 1 flexibility routine. If your client's in stabilization, this is an example, right? Let's say my client has tight calves and tight hamstrings. So we foam roll, 2 sets, 30 seconds each, and then we static stretch the calves, right? And the hamstrings. Did that for their warm up, and I did it for their cool down. Now, that same client, 1 month later, in phases 2, 3, and 4. So this is going to be, let's say this is January, right? In January, they got static stretches. In February, March, and April, they're in level 2, 3, and 4. I'm sorry, phases 2, 3, and 4. Those 3 phases are all level 2. So now they're going to get active flexibility. So it's a level 2 routine. They're going to get the calves, hamstrings, same foam rolling, but now they're getting an active calf stretch, an active soleus stretch, and active biceps femoris stretch. 2 sets, 10 reps each, hold each rep for 2 seconds. Then their cool down, workout's over. I do static stretches, right? I have no reason to care about turning their muscles off. The workout's done. Month 3, that's not true. Month 5, they're in level 3 here, right? They foam roll the same muscles, right? But now they're going to do heel walks, which is a great calf stretch, hen pecs, and toy soldiers. Both of those are good hamstring stretches. And then alternating down dog. That's another one for the calf, right? So those are dynamic stretches. 2 sets, 15 reps each. And then again, for their cool down, static stretches, right? The workout's over. So that is sort of how we write out the flexibility stuff. We're going to get back into this again when we do like an start to finish full like workout design. But Charlie, how do you feel about all that? That makes sense?
Yeah, it makes sense. But I actually went over the textbook in the flexibility chapter over the weekend. So
nice, love that. Yeah, flexibility chapter is chapter 8, I believe.
Yeah,
it's chapter 7. I can never keep them straight. Well, cool. Robert, do you have any questions today?
I'm sorry. Will we also be learning certain dynamic stretches? Or will you be teaching us that, or is that
Yeah.
stuff we
So,
pick up on ourselves?
I mean, the list. So one thing I want to show you is I'm going to get you the list here. We have this exercise checklist that you can practice. This is going to go out in a couple of days. Where did I keep this? So here's the strength checklist. Here's the stabilization checklist, and here's the power checklist. Each of these lists, I'm just going to go to the stabilization one. It has what pages the techniques that fall into that category are. So here's all the SMR exercises in the book, and then here's every single stretch that's listed in your regular textbook. And then there's a sports performance one that I'm going to get you guys as well.
That's something I would want to do. Like, let's say I do an assessment and I see, the abnormalities, and I would want to see, right off the bat, be like, okay, do this and this, without having to like look it up or something.
Exactly. Yeah. And memorizing that stuff is just something that like takes time. At first, you're not going to get it on your first round. But the more you do it, the more you're like, okay, excessive lean, tight calves, and you're like, this calf stretch, that calf,
Got it.
eventually it just kind of gets into your bones, but yeah, we'll definitely be going over stuff like that for sure.
Got it, bro. Thank you.
Cool. Any other questions today, fellas?
I'm good on my end. Yeah.
Awesome. Robert, you feeling good?
Yeah, it's always a good review when we do this stuff. So
I know. We do it a bunch. It's all circular.
yeah, but you can never hear too much of it, though. That's the thing. So.
True story. All right, fellas. Well, we'll let you out of here, and I'll see you tomorrow.